Diabetes and non-diabetic hypoglycemia. Diabetes mellitus definition. A group of diseases characterized by high blood glucose concentrations resulting from defects in insulin secretion, insulin action, or both. Obesity and diabetes prevalence by age. Percent. Sullivan P.W. et al. Obesity, inactivity, and the prevalence of diabetes, and diabetes-related cardiovascular comorbidities in the U.S., 2000 to 2002. Diabetes Care 28, 1599 to 1603, 2005. Obesity and diabetes prevalence by race. Sullivan P.W. et al. Obesity, inactivity, and the prevalence of diabetes, and diabetes-related cardiovascular comorbidities in the U.S., 2000 to 2002. Diabetes Care 28, 1599 to 1603, 2005. Obesity and diabetes prevalence by education. Sullivan P.W. et al. Obesity, inactivity, and the prevalence of diabetes, and diabetes-related cardiovascular comorbidities in the U.S., 2000 to 2002. Diabetes Care 28, 1599 to 1603, 2005. Obesity and diabetes by activity. Sullivan P.W. et al. Obesity, inactivity, and the prevalence of diabetes, and diabetes-related cardiovascular comorbidities in the U.S., 2000 to 2002. Diabetes Care 28, 1599 to 1603, 2005. Obesity trends. Diabetes trends 1990, 2001, 1990, 2001. These maps show the dramatic increase in obesity and diabetes in the United States from 1990 to 2001. This increase is important because obesity is a major risk factor for type 2 diabetes, and because about 55% of adults in the U.S. who have diabetes are also obese. CDC. Reference: BRFSS, CDC 1990 to 2001. Centers for Disease Control and Prevention. Prevalence of overweight and obesity among adults with diagnosed diabetes. United States, 1988 to 1994 and 1999 to 2002. MMWR. 2004 /53, 1066 to 1068. BRFSS, 1990 2001, A Crisis in the Making. Millions of Americans diagnosed with diabetes. A crisis in the making. 20 million American adults have impaired glucose tolerance, IGT. 13 to 14 million Americans have impaired fasting glucose, IFG. 40 to 50 million Americans have metabolic syndrome. In 2002, diabetes-related costs in the U.S. were $132 billion. Average annual cost for medical care for people with diabetes is $13,243 versus $2,560 for persons without diabetes. American Diabetes Association Standards of Care. www.diabetes.org. Access 13 February 2008. American Diabetes Association Standards of Care. www.diabetes.org. Access 13 February 2008. National Guideline Clearinghouse. Diabetes and pre-diabetes types. Type 1, formerly IDDM, Type I. Type 2, formerly NIDM, Type 2. Gestational diabetes mellitus, GDM. Pre-diabetes, impaired glucose homeostasis. Other specific types. Diabetes type 1 represents about 5 to 10% of all cases of diabetes. 2 forms. Immune-mediated, beta cells destroyed by autoimmune process. Idiopathic, cause of beta cell function loss unknown. Diabetes Care, 30, S1, January 2007. Type 1 diabetes. Diabetes type 1 symptoms. Hypoglycemia. excessive thirst, polydipsia, frequent urination, polyuria, significant weight loss, electrolyte disturbance, ketoacidosis. Type 1 diabetes causes immune-mediated idiopathic, cause unknown. Genetic predisposition. Autoimmune reaction may be triggered by viral infection, toxins. Destroys beta cells in pancreas that produce insulin. Idiopathic, cause unknown. Strongly inherited. African or Asian ancestry. Diabetes Care, 30:S1, January 2007. Type 1 diabetes pathophysiology. At onset, affected persons are usually lean, have abrupt onset of symptoms before age 30. Honeymoon phase, after diagnosis and correction on hypoglycemia and metabolic derangements, need for exogenous insulin may drop dramatically for up to a year. 8 to 10 years after onset, beta cell loss is complete. Diabetes type 2. Most common form of diabetes, accounting for 90% to 95% of diagnosed cases. Combination of insulin resistance and beta cell failure, insulin deficiency. Progressive disease. Ketoacidosis rare, usually arises in illness. Diabetes type 2. Diabetes type 2 symptoms. Insidious onset. Often goes undiagnosed for years. Hypoglycemia. Excessive thirst, polydipsia. Frequent urination, polyuria. Polyphagia. Weight loss. Diabetes type 2 risk factors. Family history of diabetes. Older age. Obesity, particularly intra-abdominal obesity. Physical inactivity. Prior history of gestational diabetes. Impaired glucose homeostasis. Race or ethnicity. Diabetes type 2 pathophysiology. Results from a combination of insulin resistance and beta cell failure. Insulin resistance, decreased tissue sensitivity or responsiveness to insulin. Endogenous insulin levels may be normal, depressed, or elevated, but inadequate to overcome insulin resistance. Diabetes type 2 pathophysiology. Insulin resistance. Compensatory in insulin secretion, glucose remains normal. As insulin production fails, postprandial blood glucose. Liver production of glucose increases, resulting in fasting blood glucose. Glucotoxicity and lipotoxicity further impair insulin sensitivity and insulin secretion. Gestational diabetes mellitus, GDM. Glucose intolerance with onset or first recognition during pregnancy. Occurs in 7% of all pregnancies, 200,000 cases annually. Does not include women who have diabetes diagnosed before pregnancy. Usually diagnosed during the second or third trimester of pregnancy when hormonal changes cause insulin resistance. May or may not require insulin treatment. Diabetes Care 30, Supplement 1, January 2007. Pre-diabetes, impaired glucose homeostasis. Impaired fasting glucose, IFG. Fasting plasma glucose, FPG, above normal, greater than 100 mg/dl and less than 126 mg/dl. Impaired glucose tolerance, IGT. Plasma glucose elevated after 75 grams glucose load, greater than 140 and less than 200 mg/dl. Diagnosis and classification of diabetes mellitus. Diabetes Care 2007 /30:S4246. Metabolic syndrome characteristics, insulin resistance. Compensatory hyperinsulinemia. Abdominal obesity. Dyslipidemia, elevated TG, low HDL. Hypertension. Risk factor for cardiovascular disease and glucose intolerance. Methods of diagnosis: fasting plasma glucose, FPG. Casual plasma glucose, any time of day. Oral glucose tolerance test, OGTT. Not generally recommended for clinical use. Revised diagnostic criteria. Standards of medical care in diabetes 2007. Diabetes Care 30:S4S41, 2007. Screening for DM or persons greater than 45 years, repeat every 3 years. High-risk persons, screen at younger aging more frequently. Overweight, BMI greater than 25. First degree relative with diabetes. High-risk ethnic population. Delivered baby greater than 9 pounds or diagnosed GDM. Hypertensive. HDL less than 35 mg/dl or TG greater than 200. Prediabetes. Polycystic ovary syndrome, diabetes, treatment goals. FPG 90, 130 mg/dl. A1C less than 7%. Peak ppg less than 180 mg/dl. Blood pressure less than 138ths of a millimeter of mercury. LDL-C less than 100 mg/dl. Triglycerides less than 150 mg/dl. HDL-C greater than 40 mg/dl. For women, HDL-C goal may be increased by 10 mg/dl. American Diabetes Association Standards of Medical Care in Diabetes. Diabetes Care 30:S4S36, 2007. Diabetes Control and Complications Trial, DCCT. Subjects, 1,400 young adults, 13 to 39 years, with type 1 diabetes. Compared intensive BG control with conventional Texas. Results. Intensively treated patients had a 50 to 75% reduction in progression to retinopathy, nephropathy, neuropathy after 8 to 9 years. Clear link between glycemic control and complications in type 1 diabetes. Diabetes Control and Complications Trial Research Group, the effect of intensive treatment of diabetes on the development and progression of long-term complications in insulin-dependent diabetes mellitus. N. Engel J. Med 339:977, 1993. United Kingdom Prospective Diabetes Study, UKDS. Subjects, 5,102 newly diagnosed type 2 diabetic patients. Compared traditional care, primarily nutrition therapy, with A1C of 7.9% with intensively treated group, A1C of 7%. Intensively treated group microvascular complications by 25% and macrovascular disease by 16%. United Kingdom Prospective Diabetes Study Group, intensive blood glucose control with sulfonylureas or insulin compared with conventional treatment and risk of complications in type 2 diabetes. UKDS 34, Lancet 352-854, 1998a. United Kingdom Prospective Diabetes Study, UKDS. Combination therapy, insulin or metformin with sulfonylureas, was needed in both groups to meet glycemic goals with loss of glycemic control over the 10-year trial. Confirmed progressive nature of the disease. As the disease progresses, MNT alone is generally not enough, should not be considered a failure of diet. United Kingdom Prospective Diabetes Study, UKDS. Prior to randomization into intensive or conventional treatment, subjects received individualized intensive nutrition therapy for 3 months. Mean A1C decreased by 1.9%, -9% to -7%, and patients lost an average of 3.5 kilograms. United Kingdom Prospective Diabetes Study Group, UK Prospective Diabetes Study 7, responsive fasting plasma glucose to diet therapy in newly presenting type 2 diabetic patients. Metabolism 39 to 905, 1990. Diabetes management. Evaluation of glycemic control, SMBG. SMBG should be carried out 3+ times daily for those using multiple insulin injections, For PEEPs using less frequent insulin injections or oral agents or MNT alone, SMBG is useful in achieving glycemic goals, Instruct the PT in SMBG and routinely evaluate the PT's ability to use data to adjust therapy. E. American Diabetes Association Standards of Medical Care in Diabetes. Diabetes Care 30:S4S36, 2007. Evaluation of glycemic control, A1C. Perform the A1C test at least 2 times a year in PTs who are meeting treatment goals and have stable glycemic control. E. Perform the A1C test quarterly in PTs whose therapy has changed or who are not meeting glycemic goals. E. Use of point-of-care testing for A1C allows for timely decisions on therapy changes when needed. E. American Diabetes Association Standards of Medical Care in Diabetes. Diabetes Care 30:S4S36, 2007. Diabetes Self-Management Education, DSME. People with diabetes should receive DSME according to national standards when their diabetes is diagnosed and as needed thereafter. B. DSME should be provided by healthcare professionals who are qualified to provide it based on their training and continuing education. E. DSME should address psychosocial issues since emotional well-being is strongly associated with positive diabetes outcomes. DSME should be reimbursed by third-party payers. American Diabetes Association Standards of Medical Care in Diabetes. Diabetes Care 30:S4S36, 2007. Required elements of recognized DSME programs. Diabetes disease process. Nutrition. Physical activity. Medications. Monitoring, using results. Acute complications. Chronic complications. Goal setting and problem solving. Psychosocial adjustment. Preconception care, pregnancy, and GDM, if applicable. Physical activity improves insulin sensitivity in type 2 diabetes. Reduces hepatic glucose output. Reduces cardiovascular risk factors. Controls weight. Improves mental outlook, physical activity. To improve glycemic control, assist with weight maintenance, and reduce risk of CVD. At least 150 minutes/week of moderate intensity aerobic physical activity, 50 to 70% MHR, and or at least 90 minutes/week of vigorous aerobic exercise, greater than 70% MHR, is recommended. Should be distributed over at least 3 days a week with no more than 2 consecutive days without physical activity. American Diabetes Association Standards of Medical Care in Diabetes. Diabetes Care 30:S4S36, 2007. Physical activity. In the absence of contraindications, people with type 2 diabetes should be encouraged to perform resistance exercise 3 times a week, targeting all major muscle groups, progressing to 3 sets of 8 to 10 repetitions at a weight that cannot be lifted more than 8 to 10 times. American Diabetes Association Standards of Medical Care in Diabetes. Diabetes Care 30:S4S36, 2007. Effect of exercise on blood glucose. In well-controlled diabetes, lowers blood glucose. In poorly controlled, underinsulinized diabetes, blood glucose and ketones will increase. If BG 250 to 300 mg/dl, postpone exercise until control improves. Activity in presence of specific long-term complications of diabetes. Retinopathy. Vigorous aerobic or resistance exercise may trigger hemorrhages or retinal detachment. Peripheral neuropathy. Lack of pain sensation increases risk of injury and skin breakdown. Non-weight-bearing exercise may be best. American Diabetes Association Standards of Medical Care in Diabetes. Diabetes Care 30:S4S36, 2007. Activity in diabetes. Autonomic neuropathy may decrease cardiac responsiveness to exercise, risk of postural hypotension, impaired thermoregulation, etc. Persons with diabetes should undergo cardiac evaluation prior to initiation of increased activity program. Hypoglycemia and exercise in insulin users. Common after exercise. Add 15 grams CHO for every 30 to 60 minutes of activity over and above normal routines. Ingest CHO after 40 to 60 minutes of exercise. Drinks containing 6% or less of CHO can replace CHO and fluid. Adjust fast-acting insulin dose 1-2U for strenuous activity lasting greater than 45 to 60 minutes. Adjustment pre-meal rapid-acting insulin for exercise. Percent dose reduction. Level of exercise. 30 minutes of exercise. 60 minutes of exercise. Very light. 25%. 50%. Moderate. 75%. Vigorous. Source: American Dietetic Association Guide to Diabetes, 2005, p. 77. Classes of oral glucose-lowering medications. Insulin secretagogues, sulfonylureas and meglitinides. Biguanides, metformin. Thiazolidinediones, TZD, for example pioglitazone, rosiglitazone. Alpha-glucosidase inhibitors, acarbose, meglitol. Gliptins, Januvia, Galvus. American Dietetic Association Guide to Diabetes MNT and Education, 2005, p. 86, Insulin secretagogues. Sulfonylureas, glipizide, glucotrol, glyburide, glynosprist tabs, glympyride, admiral. Meglitinides, repaglinide, brandin, nataglinide, Starlix. Promote insulin secretion by the beta cells of the pancreas. May cause weight gain and hypoglycemia. Not effective in persons with little or no beta cell activity. Sulfonylureas. Indications. More effective in persons who have had diabetes for less than 5 years. Develop diabetes after age 40. Have a fasting blood glucose level less than 200 mg/dl. Do not have dyslipidemia. Are not overweight. Sulfonylureas, adverse effects. Weight gain, 2 to 5 kilograms, secondary to increased insulin secretion and overtreatment of hypoglycemia. Hypoglycemia. More common in older adults and those with impaired liver and kidney function. Also may occur with physical activity and inconsistent carbohydrate intake. Source: American Dietetic Association Guide to Diabetes, 2005, p. 83. Meglitinides, repaglinide and nataglinide, brandin and Starlix. Short-acting insulin secretagogues. Generally taken with meals to blunt postprandial glucose. Allows more flexible meal timing. Take 15 minutes before meals. Admit if meal is skipped or less than 240 kilocalories. Meglitinides, adverse effects. Hypoglycemia. Weight gain. Generally less pronounced than with the sulfonylureas. Can be used in patients with renal disease. Avoid in malnourished, elderly, persons with liver disease. American Dietetic Association Guide to Diabetes, 2005, p. 84 to 85. Biguanides, metformin, glucophage. Decrease hepatic glucose production by suppressing gluconeogenesis. Enhances insulin sensitivity in muscles. Metformin also available in combination with other medications. Metformin glyburide, glucovance. Metformin/glipizide, Metaglip. Metformin/rosiglitazone, Avandamet. Biguanides does not stimulate insulin secretion. May lead to modest weight loss, 4 to 6 pounds, during first 6 months of treatment. Little risk of hypoglycemia in monotherapy. Reduces triglycerides and LDL cholesterol levels. American Dietetic Association Guide to Diabetes MNT and Education, 2005, p. 86. Biguanides, indications. Persons with type 2 diabetes who are overweight, have elevated cholesterol levels, and elevated fasting blood glucose levels. Biguanides. Improves ovulatory function in women with polycystic ovary disease, PCOS. Reduces risk of gestational diabetes, GDM, in women with PCOS. Reduces risk of diabetes in persons with impaired glucose tolerance. American Dietetic Association Guide to Diabetes MNT and Education, 2005, p. 86. Thiazolidinediones, TZD. Pioglitazone, Actis, rosiglitazone, Avandia. Improves peripheral insulin sensitivity. Most useful in overweight persons with insulin resistance. HDL-C increases, TG often decrease. LDL-C may increase, but larger particles. Adverse effects, weight gain and edema. Patients with advanced CHF or liver disease should not take these. Alpha-glucosidase inhibitors. Acarbose, Procose, and Meglitol, Glycet, inhibit intestinal brush border enzymes. Work in the small intestine to inhibit enzymes that digest carbohydrates, delaying CHO absorption. Lowers postprandial glycemia. Alpha-glucosidase inhibitors do not cause hypoglycemia with monotherapy. Can cause hypoglycemia when used in conjunction with insulin or sulfonylureas. Treat hypoglycemia with glucose tablets or milk. Medication delays digestion of complex carbs and absorption of sugars. Does not cause weight gain, but can cause flatulence, diarrhea, cramping, abdominal pain. American Dietetic Association Guide to Diabetes MNT and Education, 2005, p. 86. Insulin. All people with type 1 diabetes need insulin to survive. Many people with type 2 diabetes need insulin to achieve good blood glucose control. Failure to achieve adequate control with oral medications. Acute injury, infection, surgery, pregnancy. 4 properties of insulin. Action, speed of onset and duration. Concentration. U100 is the concentration of insulin available in the US, 100 units/ml. Purity. Source. Most insulins are made biosynthetically, treated to yield human insulin, rapid-acting insulins. Insulin Lispro, Humalog, and insulin aspart, Novalog. Used as bolus or mealtime insulins. Onset, within 15 minutes. Peak, 60 to 90 minutes. Duration, 3 to 5 hours. Short-acting insulins. Regular insulin, Novalin R, Humulin R. Onset, 15 to 60 minutes. Peak, 2 to 3 hours. Duration, 5 to 8 hours. Slow onset means it must be taken 30 to 60 minutes before meals. American Dietetic Association Guide to Diabetes MNT and Education, 2005, p. 86. Lispro versus regular insulin. Intermediate-acting insulins. NPH, Humulin N, Novalin N. Cloudy appearance. Onset, 1 to 2 hours after injection. Peak, 6 to 12 hours. Duration, 18 to 24 hours. Long-acting insulins. Insulin glargine, Lantus. Insulin Detamir, Levemir. Relatively constant peakless over 24 hours. Clear in solution. Cannot be mixed with other insulins. Usually given at bedtime but can be given before any meal. Time must be consistent. Insulin glargine versus NPH. Premix insulin 70-30, 70% NPH, 30% regular. Action times of human insulin regimens. Onset. Peak. Duration. Rapid acting. Lispro, aspart. Less than 15 minutes. 0.5 to 1.5 hours. 2 to 4 hours. Short acting. Regular. 0.5 to 1 hour. 2 to 3 hours. 3 to 6 hours. Intermediate. NPH. 6 to 10 hours, 10 to 16 hours. Mixtures. Dual insulin mealtime dose. Mealtime or bolus dose, rapid-acting or short-acting insulin is given before meals to mimic normal insulin response to a meal. Adjusted based on the CHO content of the meal. Can establish an insulin to carbohydrate ratio for an individual. Insulin basal or background dose. Insulin required in post-absorptive state to restrain endogenous glucose output from the liver. Limits lipolysis and excess flux of fatty acids to the liver. Insulin dosing, type 1. Normal weight persons with type 1 require 0.5 to 1 μ/kg of body weight. About 50% is used to provide for basal or background insulin needs, NPH or glargine. Remainder, lispro or aspart, is divided up among the meals or giving about 1 to 1.5 U insulin per 10 grams CHO consumed. Higher amount is needed in the morning due to higher levels of counterregulatory hormones and surging blood glucose levels, dawn phenomenon. Insulin dosing, type 2. Persons with type 2 may require insulin doses in the range of 0.5 to 1.2 U/kg. Large doses, greater than 1.5 U/kg, may be required at first to overcome insulin resistance. American Dietetic Association Guide to Diabetes MNT and Education, 2005. Insulin pump therapy. Provides basal rapid-acting or short-acting insulin pumped continuously. Insulin dosing. A single dose is seldom effective in achieving good blood glucose control in either type of diabetes. Insulin may be added at bedtime for persons with type 2 diabetes to suppress nocturnal glucose production and normalize fasting glucose with oral meds during the day. Flexible insulin regimens allow flexible meal plans. Involve multiple insulin injections, 3 or more, or the use of an insulin pump. Half of the required insulin dose is given as a basal or background insulin. Half is divided and given before meals, bolus or pre-meal insulin. Allows increased flexibility in choosing when and what to eat. Flexible insulin regimens allow flexible meal plans. The total CHO content of meals is the major determinant of the mealtime rapid-acting insulin dose. Individuals can be taught how to adjust mealtime insulin based on CHO content of the meal. However, consistency in meal intake promotes improved glycemic control.